I don't know.
Thank you, Freddie. It's probably safer for me to...
That one there. I will.
Good evening, ladies and gentlemen, and Mike, obviously, welcome. Just to introduce myself, first of all, I'm Trevor Fernandez. I'm a GP in Decorum, have been for about 27 years now, and I've been a resident of Decorum for 30 years, so I do understand the emotions of all of this. But I think we've got to remember that we're all here because we want a safe, effective and affordable service for our patients and their health. And therefore, hopefully we can work constructively on that. Just to start, a couple of housekeeping things. Has anyone lost their glasses? They were left outside. Specsavers look like reading glasses. Yeah. Okay, well, I'll leave them down here, and if anyone remembers, we can find those. So I think there are no fire alarms planned. Exits are there, and loos are downstairs at the back. Yeah, we'd probably prefer people to head out the back. If you're right at the front, maybe nip there, but yeah. We've had a number of these meetings before, so during the process. So through it, we will be doing a presentation, and we're trying to pitch the information both for those who've been through all the meetings, but also those who might be new to it. And just in case you weren't sure why you're here, this is an update on plans for redevelopment of West Herts Estate. We're going to do a presentation, talk you through where we're up to in the process, and provide information about the options we've got down to, and the discussion that both Herts Valleys CCG and West Herts Hospitals Trust had when we met last week. And that meeting concluded with a sort of indication of which of the four is the preferred way forward on the basis of the information we had at that meeting. So the first thing to say is we're aiming to finish by 9, and the presentation we're aiming to take hopefully under 45 minutes. So if you do just let it run through and save questions for the end, that probably will help things go more smoothly and allow plenty of time for questions. The aim is to, and with those questions, we aim to answer about this process, the strategic outline case, and maybe not other aspects of NHS care that might not be so relevant to this important issue. You'll notice a camera there. We're filming the presentation. That'll be online on the CCG and Trust websites tomorrow, and we'll also note down all the questions and answers for the meeting. We're not filming the actual Q&A session because it's just in terms of allowing people to do it without having to sign forms and stuff like that. So, I mean, obviously, you know.
Okay, thank you, Nigel. So I think we just had a minute conversation with. No, it's fine. Don't worry. So Catherine Manx, I'm the Chief Exec at the Herts Valley CCG, and we've just had a conversation about the reason why we can't film it, but we can get around it, is that we need to seek everybody's permission in order to be able to film it. Whereas obviously we give our permission as presenters. If everybody's happy that we can film it, we will film it, but we need to accept that the people may not be. So we'd ask for anybody who wishes that not to be filmed to disclose that now, and if that isn't the case, then we can film. You don't want it filmed. So in that instance, then we won't be able to film it, or we'll ask. Or we can ask that gentleman if at the end of the day sorry. You could sit behind if you wished, unless the gentleman wanted to ask a question. Are you happy to sit at the back, sir, at that point? And then it will allow the rest of the whole session to be filmed. Thank you very much. So we will film, and the gentleman will sit at the back. Thank you very much. Okay.
And just on the point of permission, I think if anyone is.
We've asked the gentleman the questions to sit at the back, because that's what we'll do.
And we can cut this part out, that's not a problem. And just to say, also in terms of if anyone would like to audio record, could they just put their hands up now so that, okay, you recording the whole thing? Yep. Do we know about it? Yeah, I think, yeah, that's fine. So that's all okay, and hopefully we can then run everything smoothly. And so I think at this point, I mean, Catherine's already introduced herself, so I'll hand over to Catherine to start the presentation.
Okay, can everybody hear me? Yep, icon? Yep. No? Can you hear me now? Can we turn the volume up a bit, please? Yep, is everybody happy with that now? Yep. Okay, very good. Right, so thank you. I'm just really going to kick off very quickly this evening, because we really want to get into the main detail and the main content of the presentation in the next 45 minutes, as Trevor said. But just to reiterate a bit the main purpose of this evening's event. So we are going to present a summary of the outputs for both the quantitative and the qualitative appraisal of the options shortlist. We are going to inform you of our preliminary view of both Trust and CCG boards on our emerging preferred way forward. At this point, a decision has not been made, I'll stress that. To inform you of the next steps in that process, but most importantly for us, which is why we're going to have an extensive Q&A, is to listen to your views on that emerging preferred way forward, so we can feed it back into those meetings that are happening on the 11th of July. So very quickly then, the wider context. And we start with this because it's extremely important to make sure that whenever we're discussing these topics and the strategic position, that actually we're really clear on that actually this is not the only thing that we have to debate and discuss, particularly as clinical commissioners groups. And actually the context of healthcare sits in a wider context of a whole system around NHS health provision. And in that strategy, we have a long established strategy of Your Care, Your Future, and as well as now the STP strategy, so the Sustainable Transformation Partnership strategy. And that sets out very clearly a vision for health and social care services. It is very much focused on preventative, proactive care and care close to the home and in the community as much as possible. And actually, just a lot of people often ask, and we'll talk about the journey so far and the strategic outline case in a minute, but actually, we've actually spent nearly, as a system, now £10 million on primary care facilities over the CCG footprint and over the last 6 years. And we're going to intend to do the same over the next 6 years. So there's a huge amount of investment that goes in the system and the wider health context, not just necessarily as we talk about the bricks and mortar of hospital buildings. And in that, the way that we deliver care is also increasingly important. And then the NHS long-term plan is really clear on how digital, technology, extended primary care services and how services will integrate in that way of described around proactive, preventative care and care closer to the home. And I know in previous public meetings we've talked about a number of the services that are already live and have been put in place over the last few years in moving towards this agenda. So we know this has been quite a mountain to climb. We're here to talk about the strategic outline case for the Trust this evening, but this has been a very long journey. Trevor has talked about, he's been a GP in this part of the world for 27 years. I live in Decorah and have done for 15 years. We all of us know, I know many of these people in this room well, that this has been a long story and a long journey since the 1990s, and we mustn't forget that. But we really are now at a point where we feel that we can really start to move this forward and unlock some capital for the benefit of patients in the whole of the west of Hertfordshire. So, in doing so, we have been really clearly told and advised and spent a lot of time discussing with either the regulators or members of the community which we work with within the NHS, but not least also the political position around the national context. That we've been really clearly advised as a group of trust and also CCGs that there is limited public dividend capital available. And that they're also really clear that private finance options will no longer be supported or approved. That's something that we previously were considering, but we're not able to do so now. And as we've also talked about in other public meetings, affordability and value for money is a really key in getting that regulatory approval. And as commissioners, we have a responsibility, as do the Trust as well, but when we're looking at the whole of the healthcare that I just talked about in a minute, that the solution is affordable. And in that, the regulators have been very clear with us that the option that we put forward must not exceed the Trust's annual turnover. And I know Donna's going to talk a little bit later about how that's constructed, so it's really clear with people. And therefore, we've very much taken the view in that advice to review our SOC in this context. We're clear in the journey, which I'll come on to now. We have a timeline. It's a tight timeline. We've talked about it over the last 6 months. There's a comprehensive spending review planned, expected in the autumn. And we were encouraged to submit our SOC in time for that comprehensive spending review in order to unlock the capital that we so desperately need. So a lot of people ask us what are the next steps, what are the journey and the timeline. We're here now. Just coming into the 11th of July with the CCG board and the Trust board decisions. And then we're going to, our intention as we go through a number of different governance steps, not least with the Trust and the CCG, but also with the Strategic Transformation Partnership in July. We will then intend to submit our SOC to regulators at the end of that month, before the summer. The comprehensive spending review we expect in the autumn. And then, as you can see, over the next few years, then what we would do is then start to develop and approve many different stages that go through this development, an outline business case, and then a full business case. And people often ask, when will we start to see any change? At the earliest, we expect building works, if we're successful in all those stages, will be 2023. So there's still a long way to go, and it's really important that people recognise that in the journey of where we are.
Sorry, can I just ask, what's SOC?
The strategic outline case. So that's what we're talking about this evening.
Just a quick question. This is my first meetup. I'm a health person.
Yep.
Right? And, you know,
So could I ask if this is about the actual detail of the slides, or is it for later?
you're saying it's going back to the 1990s, right? So why is it only taking till now, and why is it going to take till 2023?
Okay.
For all this happening?
Okay, so we'll pick that up, if we'll document that question and pick it up in the Q&A. I understand your question, but if we could just ask, as we said, we'll keep going with the presentation, we'll take questions when we've finished, if that's okay, but we'll come back to that question. Okay, I'm going to hand over to Anna next.
Thank you very much. Good evening. My name's Dr. Anna Wood. I'm a consultant haematologist. I've been at the Trust for many years, and I'm also Deputy Medical Director. So I really would like to recap the case for change, and I'm sure many of you have already heard this, but from a clinical perspective, it's an absolute must-do. We can't continue as we are. So what are the joint objectives that we have with our CCG and the Trust? Well, there are three main ones. Very important one is obviously if we're going to deliver clinical care, proper clinical care, we have to do that in fit-for-purpose buildings. And these buildings have to flex for future demand. Secondly, the premise of the change is the clinical model. That's the absolute key to this. And we've spent a lot of time being involved in developing the clinical model, which my colleague, Mr. Freddie Banks, will be discussing in more detail in a few slides. But an important part of this, and I think a lot of you have probably already heard this, is that one of the key things is that we do have to separate our acute care from our elective or our planned care. Simple example is when you come in to have surgery, you'd like to have it done on the day that you were going to have it. And in the way that our model works at the moment, that's not always possible. Thirdly, we absolutely have to do this within an affordable financial envelope. We can't ask for more than we will get. And not only does it have to be affordable, it then has to be sustainable. So, I just wanted to give us a few hard facts about our estate. We know that just over half of our buildings in our estate are actually below the minimum standard for care. And the majority of those have been classed as poor or below standard and in worse condition than previously, when inspected previously. We're supposed to have about half of our bed base as single rooms, but at the moment it's only about 10%. And our bays as well are only about half the size that they should be. So we don't have the correct model at the moment, and we absolutely have to have an improved standard of care, and our state has to improve. Our delivery suite as well, really important part of our care, is too small as well. Clinical adjacencies and clinical relationships are extremely important. I'm not going to go into too much detail about this, but you have to have certain co-locations of clinical groups. And at the moment, our theatres are too small, the ventilation is very fragile, and some of the post-operative recovery is inadequate. We have to separate our children from the adults. As you know, we have a deficit, a financial deficit. And if we continue as we are, then the backlog maintenance of that, of the estate, is an eye-watering 189 million. And it would be twice that in order to make these changes to make us fit for purpose. So I don't wish to depress us, but a few clinical scenarios that have affected our business and continuity only since this April. We've had certain circumstances where we have a lift 9, that keeps breaking down, and it means that our patients who have to go from one building to another have to go via ambulances. And that's not good for the patients, and it's also not good in terms of our finances, and we're draining more money because of that. We've had waste in ED, and we've had to close cubicles. We've had loss of ventilation in theatres, and the theatres were down for about 3 hours. So we're having to deal with things like this on an almost weekly and monthly basis. So I'll stop here. Thank you. I'll pass on to Tracy.
What were you talking about then? Watford?
Oh, yes.
Yes. Thanks. Hello, my name is Tracy Carter and I'm the Chief Nurse at West Herts. So I'm just picking up on what Dr. Anna Wood has already said, just to show you some pictures in terms of the bays on the wards, and around a 6-bedded bay, and actually we need 4-bedded bays to allow much more privacy and dignity for patients, and supporting infection control and flexibility of the use of the hospital. And as you can see here, a quote from myself around the need for more rooms within the hospital to allow for privacy and dignity, managing infections as part of that, and actually really improving patient and family experience. And Colette Mannion, who's my Director of Midwifery, talks about the experience of mothers on the delivery suite, and actually the need to be able to have much bigger rooms for what is a really special time in women's lives, along with their families, so that they have much more privacy and dignity in facilities that are much more appropriate as part of that. And I'm going to hand over to my colleague, Patrick Hennessy.
Evening, everyone. Paddy Hennessy is my name. I'm Director of Environment. So just to touch on IT is quite like some of our estate. So some of it is quite old, spread across the site, sometimes tucked away in areas that makes it very, very difficult to maintain. So with regards to the estate, so my colleagues touched on some figures earlier. So we carried out a 6-facet survey last year. The costs to bring the estate up to condition B is 189 million. If you understand the 6-facet survey, so there's physical condition, functional suitability, statutory compliance, quality, and a couple of other facets. The split across the 3 sites, so it's about 63% investment required at Watford, 28% at Hemel, and 9% at St Albans. So to give you an idea of the spread of those costs. And I'll hand you over to Freddie. Thank you.
My name is Freddie Banks, and I'm a consultant urologist and associate medical director at West Herts Hospital. So models of care are changing, and one of the key components of care moving forward is that we should try to deliver care much closer to your home. The traditional model of seeing your GP in primary care and then coming up to the hospital for investigations, going on a little bit of a roundabout at the hospital and then being spat back down to your GP again is outdated. We need to move into a much more cohesive and integrated care where the consultants in the hospital are supporting GPs, the community services are linked in with you, and the idea is that as much of your care can actually be delivered. So we want to get as much of your care delivered at home, close to home, and you'll minimise your visits to the hospital. So a good example of this is I'm a urologist, so this is our pathway currently for prostate cancer. Now the target is that we have to deliver this in 31 days. So you come up to a hospital and you can come up to Hemel, St Albans, Watford and see a consultant. There's only 4.5 consultants at Watford, so we're spread pretty thinly. You then will have to go and have an MRI scan. Now, we don't have enough capacity at any of the hospitals to deliver that here, so we have outsourced to Spa Bushy. So you then have to get in your car, a designated point, and go to an appointment down at Bushy. All the paperwork has got to get there, so there's clerks from every single hospital sending all the stuff down. You then have your scan at Bushy. All the paperwork and the scans have now got to come back to any of our hospitals in the trust. You then have a biopsy at St Albans. That's where we do the biopsies because it's complicated, expensive kit to do it. That biopsy's then got to go to Hemel Hempstead to be processed, because that's where the pathology department is. The results have then got to be sent back to whichever clinic you're going to, whichever hospital. You then will probably have to have a bone scan. That will be done at Watford Hospital. You then have a joint appointment with an oncologist who comes from Mount Vernon and a pelvic surgeon who comes from Stevenage Hospital. And depending on whether you need to have radiotherapy or radical prostate surgery, you'll then go either to the Lister Hospital at Stevenage, and that's a cancer network decision, or Mount Vernon. And then eventually you'll come back to Watford Hospital for ongoing follow-up, and as much as possible, if you've got stable disease, we can then get you back into the community and support your GP while we use telephone clinics for follow-up. Sorry? That's the MRI facility. It's a private hospital, Sparks private hospital. To me, that is absolutely crazy. Now, the amount of admin staff, clerkings that have to go on to deliver that. My junior doctors finish a clinic with me at Watford, jump in their cars, run across to Hemel. The other junior doctor from my clinic goes to St Albans. It is difficult. Difficult to manage, difficult for patients, difficult for staff. And that should not be a standard of care in 2019. Numerous hospitals have delivered a one-stop service, and that needs to be the principle for all cancer diagnoses, for all specialties going forward. And that means co-locating the teams together with the radiology so that you can have as many investigations done as timely and as efficiently as possible. So the idea of going forward is that you can get virtually all of this done in a one-stop setting. You might spend quite a long time at the hospital, but you can see a consultant, have the initial investigations, get your scan, try and get your results of your scan, get your biopsy, and actually go home with a provisional diagnosis. And that is what we want to be able to deliver as clinicians, and is what you as patients should ask for. Not a multi-step pathway. You want to come to one point, a single point of reference. See the cancer nurse in the hospital immediately after you've seen the consultant when you got back.
What if you live near that particular hospital?
Sorry?
Which is fine if you live near that particular hospital.
Yeah.
If you don't, then you haven't got time.
But this is quality of care for all patients in West Hertfordshire. That is what it is about. And that is what we should aim to deliver, and what our new buildings and redevelopment of the hospital will deliver for you. Thank you. I'm going to hand over now.
Hello, Tim Duggleby. I'm the Associate Director with responsibilities within the Trust redevelopment team to do the engineering design for our future hospital services. And what I'd like to do now is just spend 5 minutes running through the options that we've been considering and just try and give you a little bit more information about each of those options. Those of you who've been to earlier presentations will be aware that we started off with a long list. We reduced a long list of options down to a short list of 4 options. And those 4 options are shown on the slide here. What they effectively do, moving from left to right, is change the level of investment between your emergency services and your planned care services. So starting on the right, on the left-hand side, the majority of the investment in option 1 is on emergency care at the Watford site, but we do retain the other 2 hospitals at Hemel Hempstead and St Albans delivering planned care. As we move across to the 2 centre options, we're moving away from a 3-site solution to a 2-site one, where emergency care still remains at Watford, but planned care will either be on the St Albans site or the Hemel Hempstead site. And as we move to the far right-hand side, you then keep your emergency care at Watford, but you build a new planned care facility midway between Hemel Hempstead and St Albans, and you deliver your planned care from that new facility. So now just to give you a little bit more of a feel for what each of those does. The starting point for any sort of analysis of what we do is where our patients go. And what this slide very quickly summarises is the fact that the great majority of patients who come to the Trust come to the emergency care hospital, whether it's for A&E activity, or it's for planned care activity, or non-elective activity, or our outpatient things. The majority are still coming to the emergency care site, and that gives you just a breakdown of those numbers. If we now move on to our estate, Paddy's told you the condition of our estate. All you need to look at in these pictures is the bits that are in red. The bits that are in red are the buildings across each of our sites. So starting with Watford, moving on to St Albans and Hemel, those bits in red are bits where we need to do something with the buildings in the next 5 years. There is no choice to carry on with them. We need to be doing something within 5 years with all of those buildings. So going through what each of our options is proposing. Option 1, what we intend to do in option 1 is the majority of the investment is at Watford in the emergency care site there. Looking at the picture here, the buildings that you see in green here are, after our redevelopments occurred, are new buildings. So a major new ward block here, accounting for circa 200 new beds in a new ward block there. A major new clinical block there, which will give our women's and children's services, provide new operating theatres and new critical care facilities. And having built those, we're then able to refurbish our main block at Watford so that the wards and remaining facilities in there are brought up to a standard that's acceptable for modern healthcare. Once that work is complete and supported by a new multi-storey car park, which hopefully will start construction next year, then we're able to free up part of the remainder of the site to support wider development, possibly housing, whilst also retaining some of the site for future development or expansion to cover future healthcare needs. The only building that we're intending on this proposal to retain with minimal extra work in it is the new acute admissions unit that was built just under 10 years ago. At St Albans, at the same time, we need to do some work to bring that up to the standard we need to deliver proper planned surgery, and this we're going to do by creating a new block in the centre of the hospital site, as it currently is, as a new diagnostics and cancer centre, picking up on the work that Freddie talked about earlier on, about our need to bring one-stop shop clinics into there. And we're at the same time going to do some work on the main theatre block to give us an additional theatre there and to upgrade one of our current theatres, as well as doing some basic backlog maintenance work on the site as well. Under this option at Hemel, what we would aim to be doing there is to concentrate the activity, which is planned medical activity, into as small, as reasonable a footprint as we can on the site, so we can deliver effective adjacencies for clinical services and minimise the inconvenience of moving around the site that those who use the Hemel Hospital currently experience. We also accept the fact that we're going to need to, in order to free up this site, we're going to need to relocate some services into a new building, so there will be some new building on the Hemel site, as well as major refurbishment within existing buildings. This frees up an area potentially available for development of housing within the centre of Hemel Hempstead for around about 200 houses. If we move on now to, just let me run through quickly so we can pick up some questions at the end. Option 3, and this is just an example of one, but we're focused on this one because this is the one that's the most sensible economically for us, which is then to bring all the services, planned care services together into Hemel Hempstead. And if we were to do that, that means significant extra investment on planned care on the planned care site at Hemel. To get that extra investment, you have to do less on your emergency care site. And what that means for us on the emergency care site is that a number of the floors around proposed new ward block wouldn't be built. So we would get much less new bed space at Watford. We're not able to put a new theatre block at Watford. So the theatres would remain in the existing main building at Watford. Also, because we couldn't do this extra new build at Watford on the bed base, we're having to leave at least 2 floors of our existing main building at Watford without refurbishment, which is somewhere between 100 and 200 beds would not be changed from the existing 6-bed configuration to 4-bedded bays. So there is significant trade-offs if we go down that model. However, there are benefits, and the benefits of this model are that you are able to move in this case, your surgical activity from St Albans into Hemel Hempstead into a brand new surgical block. So your planned surgery and cancer and diagnostics would be in a new building on the Hemel site, and you would then have to do some rearrangement of your car parking, just a reality of life, and still be able to release some land, but less for disposal. So that's the sort of two-site option, bringing activity together, significant advantages in doing it, but big trade-offs at Watford. If we look at the fourth option, which is the brand new planned care facility, somewhere midway between Hemel and St Albans, the trade-offs at Watford are even more significant there. If we were to go for that model, there is almost no refurbishment of the bed base at Watford. So most of those 6-bedded bays would remain exactly as they are. Quite a lot of the backlog maintenance work would still remain to be done. And so there's a big backlog maintenance liability to deal with. And again, most critically, we wouldn't get the theatres, we wouldn't get the new critical care facilities and any advantages of that at Watford. But what you would get potentially is a brand new planned care hospital, circa 20,000 square metres of hospital, which would be brand new theatres for planned care, a new planned medical centre within that, and facilities very much on a line with the example of down at Chase Farm, which was opened earlier on this year. End of last year. And again, the location for this would be midway between them. We have not got a definitive site, but there is available land that we could build on should we decide to go down this option. So that's a quick run through of where the option take us. Just to very quickly summarise what that means in terms of investment, option 1, 80% or so of your investment, 85%, up to 85% of your total capital investment is going into Watford. If you look at the option 4, it drops down to 50% into your emergency care and 50% on your planned care. So that's where the difference in money goes. And that's a very quick run through of what each of the options do, and hopefully gives you a little bit of feel for what they mean.
Thank you, Tim. So I've got one of these mics on. Is it working? Can people hear me? Can we turn me up a little bit? Can you hear me now? Yes, thank you. Okay, so my name is Helen Brown. I'm the Deputy Chief Exec at West Herts. I've been involved in this process for 5 years, worked at the Trust for 5 years. So I'm just going to briefly talk you through the stakeholder panel that we held earlier in this process, which looked at those 4 options. We had just over 30 people in the room with us on that day, a mixture of clinical staff from the Trust, some colleagues from the CCG, some patient representatives, Health Watch, some other organisations with us. And what we did was we looked at each of the options that were presented, and we scored them using this scoring system. So if they gave us a benefit, we scored between 1, 2 and 3, and if we thought they didn't have benefits or negative benefits, they were scored with negative. And we discussed it together, but everybody scored individually. The role of the panel was to undertake that exercise and for us to get a set of views in a structured way from a range of different people. It's an advisory panel, so the answer from that panel doesn't equal full stop the answer that we go forward, but it is absolutely part of this process and how we do reach a judgment on the best way to go forward. The panel met 3 times, but the key date was the 13th of March where the scoring happened. So the outputs from that panel, if you take all of those scores together and add them all up and then divide them by 31, option 1 scored the highest overall with an average score of 1.5. So this was considered to be what we called a slight to moderate positive impact. I will come back to that in a second. This was followed fairly closely by options 3 and 4, which scored 1.3 and 1.2. So option 4 was the second highest scoring option, closely followed by option 3. Option 2 and the do minimum score both scored negatively. And I think it's understandable why do minimum scored negatively, because the view was that if we could only invest a relatively lower amount of money in the buildings, we wouldn't get the benefits that we needed, and over time that would only make it more difficult to deliver care. Option 2, that did score less well than option 3, so the St Albans version of bringing it together onto 2 sites, and that was largely to do with the constraints of the St Albans site. It's it's got less flexibility. There's more space at Hemel to redevelop, and therefore that was going to result in more compromise in the solution. And particularly there were concerns about car parking on the St Albans site if we put all of those services there. So that was what was driving a lower score for option 2, and that's why we haven't spent time talking to you about it today, because it was clear from that session that if we were going to a 2-site model, we didn't think St Albans was really a viable model. There were differences in how different people scored the options, so I'm going to show you the slides. This is overall we scored against safety and outcomes, patient experience, workforce impacts and future flexibility. It is really important that we keep some flexibility for the future, and different options have different benefits. So you can see that the options score slightly differently, but the bottom line score there are the ones that I just talked you through. If you look at it by different groups, there were different views. So the clinical staff in the room and the staff who represented the trust scored option 1 more highly relative to the other options than other people did in the room. You can see that the patient representatives in the room thought that both option 1 and option 4 had good benefits and were less positive about option 2 and 3. So that just gives you a different way of looking at it, and it shows that there are a range of views and different people express those views. This is just a brief summary. I'm not going to repeat that because Tim's already talked you through some of the advantages and disadvantages of the different options. So I'm going to hand over now to Don, who's going to talk you through the financial analysis that we've done.
Right, thanks. I also have one of these devices. Can you hear me? Yes. Excellent, good. My name is Don Richards. I'm the Chief Financial Officer for the Trust, and as Helen said, I'm just going to quickly try and take you through the financial evaluation that we've discussed in our Finance Committee and Board, which helps with the decision that we arrive at ultimately. So the financial evaluation, if I get to the slide, comprises, I guess, three things. First of all, how much is it going to cost us to build the development, to develop the 3 sites? Secondly, what's the impact of that investment going forward in terms of running costs? And thirdly, perhaps most importantly to our regulators, what does that do to the Trust's finances on an ongoing basis? So the first slide is just a summary of how we've arrived at the costs for the different options, the capital costs, the one-off costs. So what this slide does is it as you can see, summarises each of the options, ranging from do minimum right the way through to option 4. It starts with departmental costs. Now these costs are largely driven by national guidance. We start with an estimate of how many patients we expect to treat when the development arrives. That tells us roughly how large we need to build the hospital, and also what sort of departments we need to put in, what's the size of those departments, and roughly how many square metres we need to apply to those. Now there are published national numbers that tell us how much different departments cost per square metre. So an intensive care unit or an operating theatre might cost more per square metre than a ward, for example. So we use those nationally published numbers with the sizing that's derived from the numbers of patients that we expect to come through to arrive at what we call departmental costs. That's only the beginning. We then need to add on other elements that will cost us money if we are going to build a fully functioning hospital. I should say as well, actually, that in putting these together, we've had the benefit of an informal review by an expert from NHS England, and also this work was put together by expert cost consultants that the Trust commissioned to help us with all of this. So, well, it should reassure you that all of this is objectively done, and it's not my team sitting in their offices crunching spreadsheets. So on top of the on top of the departmental costs, we need to take into account external works, drainage, things like that, and that's represented by the second line. In addition, we're mandated to allow for a location adjustment. So there's a straight percentage there which reflects the location that we're looking to develop the hospitals on, Hertfordshire, West Hertfordshire. On top of that, obviously, we need to allow for project fees, that's architects, surveyors, and so on, and that's a straight percentage as well. And then we have to allow for legals, building regulation costs, and so on, and those are summarised in a line called non-works costs. At this stage in the process, now I have to just remind everybody, this is very early in the process. This is just the first stage. After we've done this and after it's approved, we then need to do another business case. We then need to go out to tender, and then we need to produce a final business case. So at this stage, costs are relative estimates. So, not quite 20 years, but you remember the timescale that Helen and Catherine referred to earlier? So this is how we get the money from the Department of Health. We have to go through these processes in order to get the money. We can't just ask for it. We have to show our workings, produce business cases, and so on. Equipment, an estimate, we allow 20% at this stage in the costing process for equipment. We have to allow for costs around planning, and what we've done is we've varied those costs depending on how complicated the developments are. So option 4 involves a new plot of land, a brand new hospital, so the planning costs are likely to be more expensive than the other options. We're also mandated as well to account for something called optimism bias. Now, our regulators in the Department of Health are concerned that when organisations put together costs at this stage in the process, we tend to underestimate the costs. So they've mandated a percentage that we have to apply to the costs called optimism bias. And there are rules around how you apply that. When you're in the early stage of the process, you apply a higher percentage. As you go through the steps, you can reduce that percentage. And it also varies depending on how complicated the project is. We then arrive, and you can see the cost estimates that we've arrived at this stage, and they are all around, apart from the do minimum, and we don't want the do minimum, around the £350 million mark that Helen referred to earlier, which is equivalent to our turnover. Just to be more precise around our turnover, those of you who've seen our accounts for 2018-19 know that we earned £333 million in that year, which was our turnover. We're planning to earn £365 million in 1920. So our regulators will mandate that our capital cost is within that range. And you can see if we bring forward the numbers from the previous slide, we've also accounted for net land sales. That's land that we expect to sell as a result of the development, offset by land that we have to purchase to make the developments happen for some of the options, especially option 4. And then we arrive at the net capital requirement as a result of that. Now, at another one of these meetings, I answer the question about why £350 million is a sensible number. And this slide tries to explain that. So in the top right-hand corner, what this describes is the fact that if we get the when we get the £350 million, it will be given to us in the same way that shareholders give money to companies. They invest. It's equity finance. With equity finance, you have to pay your shareholders a dividend. We have to pay the Department of Health a dividend. It's mandated that it's 3.5%. That's a dividend we have to pay every year. Now, on £350 million, that's 12.3 million. So we have to take that into account in our finances. We also have to depreciate the asset as well over 60 years, and that's worth roughly £6 million. So in total, our costs will go up by £18 million per annum as a result of making this investment. When we put our business case together, we need to show our regulators how we can cope with that £18 million. We have to make savings to cope with that. That £18 million, when you compare it to our turnover, which is £350 million, is worth about 5% of our turnover. And that's right at the upper end of savings that we can expect to make. And this graph shows that the higher the capital expenditure, that we invest, the higher the capital charges, and as a consequence, the bigger the savings we have to make. And we don't think we can make savings in the order of an extra £30 million a year if we invested £700 million. So that's one of the reasons why it's sensible to peg the investment at around about the £350 million mark. I'll try and explain equivalent annual costs. What this is about is bringing together the capital cost, the ongoing costs of the development, the benefits that we expect in terms of savings. So we expect savings to come from reduced estates costs, but also reduced clinical costs because we can deploy our staff more efficiently. And all the other changes, as well as the residual value of the investment that we make. At the end of 60 years or 30 years or whatever, depending on the option, there will still be value associated with each of the investments. We need to take that into account in terms of appraising the economic benefit that we get from each of the options. So all of that is brought together to arrive at what's called a net present value. That is then annualised. It's divided by the number of years that the investment relates to arrive at what we call an equivalent annual value. Now the benefit of that is it allows us to objectively compare the options to say which option gives us the most value. And what this slide says is that option 4 at the moment with our costings gives us the most benefit. And obviously, as you'd expect, just patching up our hospitals gives us the least benefit. So we take that into account when we're deciding on which option we need to choose. Final slide for me, the final bit of our appraisal. What does it do to the Trust's finances? So what this graph shows is the trajectory of our annual deficit each year under a number of different scenarios. So the blue line, I think it is the blue line, isn't it? Yeah. It was the blue line. There was a do nothing. Yeah, there it is the blue line. The blue line shows what we expect to happen if we do nothing. So we're working with a 5-year savings program, and we expect that to improve our finances. This year we're heading for a deficit of £23 million compared to £49 million last year, so a big improvement. We expect that improvement to continue, but we can't keep cutting costs forever without significant investment. So we then expect the deficit again to return back to the levels that we were experiencing last year. The investment, as I described earlier, results in our costs increasing because of dividend payments and depreciation. But then once it's completed, we expect savings to come through at a higher rate than we were able to achieve previously. And what this slide shows is that option 4 gives us the best benefit, and it takes us to a break-even position slightly earlier than option 1. And what we have to do is judge whether the difference here is material enough to choose one option over another. And that's a decision we have to take, not just now, but when we complete other iterations of the business case. I'm going to hand back to Catherine now, I think. Thank you.
Okay. Not on? Okay, don't worry, I'll pick the mic up. Okay. Can you hear me now? Yep. So we're just Christian and I are just going to finish off our presentation before we move into questions. But important part of what I spoke about at the beginning was also all the, some of the financial analysis that Don's referred to, the clinical analysis, but also all the qualitative analysis that goes behind some of the thinking that we've done and the stakeholder work that we've engaged with. And one of the things that we do both as the Trust and the CCG is look at the impact on equalities as part of any decisions that we make. Our equalities and quality impact assessments, and they're extensive, and they will be as part of the discussions that we have on the 11th of July. I'm not going to go through some of these now, but basically what this slide does is tries to summarise for each of the options some of the impacts, particularly on protected groups, that the different options have, plus also at the bottom the do minimum option, and we'll consider those further again on the 11th of July. Just to finish off then on the stakeholder engagement that we've done to date and the views that have been expressed, just to summarise for those people who either have been to these sessions or have not been to these sessions, so you feel like a comprehensive summary of what we've heard so far. We have had quite a suite of extensive public meetings. Some of you obviously been present, leading to today's discussion. Already since the latest stock that we're proposing here today in the submission from October 2018. We've had a significant number. I know the team have spent an extensive amount of time responding to questions and correspondence. Some of it comes from public meetings, but also a lot of it comes from other general correspondence. We've had over 250 items and documented written correspondence. We have met and briefed all our local MPs and also all the local authorities, either through scrutiny committees, health and wellbeing boards, partnership meetings, and extended sessions at Hertfordshire County Council. And there also have been updates to the Sustainability and Transformation Partnership, and there's a further one to come at the end of July that I referred to earlier. And I know many discussions at our patient participation involvement groups and other patient groups, not least one today, around the proposed emerging way forward. We shouldn't forget that a lot of this change will also be about the impact on staff, and our Equalities Impact Analysis looks at this really carefully. And therefore, we've done an extensive amount of engagement and discussion with the staff, not only at the Trust, but also with the CCG and the wider provider system within which we work. And then also our regular updates, as you'll have seen over many months, both at the Trust and the CCG, with our websites and stakeholder letters. So a comprehensive list of engagement that we've followed through with. So the summary of that feedback, and there are really only summary points. I recognise that I'm not going to be able to express everybody's view here. But the key themes and questions and comments that have come back is that, what is the rationale for redeveloping, and we'll probably discuss some of these as we go through the Q&A later. What is the rationale for redeveloping Watford as a major emergency site, bearing in mind the poor state of the current repair and location that Anna referred to and Tracy earlier? What evidence have we used to move from the long list to the short list? We've had a lot of debates in that space. Why have we discounted a new build emergency hospital when other trusts have done this in the past? And again, we'll have to talk about that in a moment. The impact on patient care. A lot of people have asked about, if you were to redevelop extensively Watford, what would that do with the continuity of care and the patient experience and safety in doing so? And not forgetting that this is all about a sustainable healthcare system and sustainable buildings, and how do we respond to that when there's such a growth in population in housing in many parts of the country, obviously, but also clearly in the West of Herts. So that's a summary of the feedback and main themes that we have had. And the stakeholder panel, which Helen referred to earlier, and their work that they've done with us. And these are the key things that emerged from that stakeholder panel. And this is a word I'm going to use quite a lot this evening, and we go through the questions, and we've used in many public sessions to date, is we recognise, and I think the recognition from the stakeholder panel, that this is a compromise. And actually the stakeholder panel played that back to us. That we actually, in making that compromise, we needed to really take into account access, travel and car parking, and they were really important in any service reconfiguration and decisions that we might make. And most importantly, people have challenged us also in the stakeholder panel, the thinking and how we prepare the strategic outline case, in how we use digital and technology to future-proof our hospital. But also we need to make sure that we try and articulate, as Freddie talked about earlier, and some of the things you see around the room, and some of the way that we've described the visuals this evening, is the potential benefits from a patient perspective. And we must remember that's the heart of what we all do. We should also recognise that some stakeholders continue to express the view that a new emergency in Planker Hospital and a new site is the only viable long-term solution. So that's a summary of what the stakeholder panel we heard from them. I'm just going to hand over to Christine to close.
Can everybody hear me? Hello, good evening. I'm Christine Allen, and I am the Chief Executive of West Herts Hospital. Just to get to the summary, have you got the clicker? Okay. So just a couple of points that I wanted to make before we move into the Q&A session. In terms of the appraisal summary, the qualitative benefits shows that option 1 scored the highest overall, but I think it's fair to say that different stakeholder groups had different views. In terms of the quantitative economic appraisal showed that option 4 has the highest EOV, which you've heard from Don just a little earlier. And the Trust and the CCG board considered those outputs and the case for change in the discussions that they have both had on the 6th of June. And the final decision in terms of the preferred way forward will be made by the Trust and the Trust board on the 11th of July. In terms of the emerging preferred way forward, option 1 should be the preferred emerging way forward that should be taken to outline business case, and you've heard that discussed earlier. And in terms of where we get to for next steps, we're just outlining those here. Hopefully you've seen most of these before in terms of the next steps for the Trust Board, the CCG, and the STP involvement, so the wider system involvement. So I know we want to get to Q&A. There's just a couple of things that I wanted to add before we get into that. So I'd just like to say, from my perspective, I am relatively new to this health system. And there are a couple of points that I'd just like to make. Investment in the estate is urgently needed. That is very clear to all of us. Our staff work incredibly hard to provide the best care that they can, and that's made more difficult because of the current estate. So in terms of option 1, the emerging preferred way forward, it enables significant investment at our busiest site with the most challenging estate. But importantly, it retains and enhances services at all 3 sites, ensuring that all of our patients and staff of the West Herts community see the benefits of this investment. So I just thought I would add that as a relative newcomer to the health system. So let's get on with the Q&A. So if I hand back to Trevor.
Sorry, will you reiterate what option 1 is, please?
Can we do that as we go through? Yeah, Tim can do that.
Do you want to quickly do that?
Do you want to flick back onto the slide? Yeah. We might just bear with me while I get back to the slide. So, what we're looking at doing in option 1 is firstly addressing the fact that Watford buildings are in incredibly poor condition. It's where the worst of our backlog maintenance is, and where we've got to produce as much as possible in the way of new build and ensure that the estate that we don't turn to new build and refurbish is put into a condition where it has a life of 20 to 30 years, not just a life of a few months. So what we're looking at doing in option 1 is a brand new ward block to put the majority of our patient wards into, which will be built to the current standards as laid down in the health building notes, not to the standards of our current buildings. We're also going to build a huge new clinical building. This building will be the same size as the main building in Watford at the moment. So a large building here which will service the women's and children's services. It will have a new theatre block in it with a significant number of theatres in it. It will have a new critical care facility, and it will also pick up services from some of the other Victorian buildings that sit around the Watford site, which will go as part of this development. So that's what we're going to fund. We're also going to refurbish the great majority of the new building. So those wards will be brought up to a standard. It will be refurbished rather than new, but they'll be brought as near as we can to the standards that the rest of this new building goes into. At the same time, we're going to get a new multi-storey car park. That means the parking issues that have dogged Watford for so long will go away and link in directly to the new road that opened a couple of years ago. So that's what happens in the Watford site, and all those old buildings that you've seen around the front of it will go, including the women's and children's building.
How many beds will it take place at the same time?
Pardon?
Is it all at the same time?
Pardon?
How many beds will that unit?
I couldn't just answer that straight away, but I'll quite happily come back to you and take the question, and we can come back to you with a direct response of how many beds. It is in the paper, I just don't have it directly to hand.
Can we get going on questions? So you haven't mentioned
Can I just very quickly run through St Albans? So what we're looking at doing at St Albans is recognising that to make it a proper planned surgical centre, we need to put investment into the areas that are picked up as failing at the moment in terms of backlog maintenance, so that the operating theatres need investment in the ventilation systems. We need to build 2 new operating theatres to replace the temporary one that's there now and the procedure room. We're going to build a new planned surgical cancer centre there, which will have the diagnostics in there with a new MRI and CT over there, which are needed to support surgical activity. And we are looking at transferring surgical activity from the Watford site, elective surgical activity from the Watford site over towards the St Albans site under that model. And we also need to do some work on the estates area to relocate and replace the existing infrastructure. And then very, very quickly at Hemel, the key thing at Hemel is to try and get away from a sprawling hospital, which is only about 40% of which is used, into a functioning hospital in as tight a footprint as we can get it to operate effectively and efficiently, whilst acknowledging some new build is required to bring all those services together. So that's broadly what each of those options runs to.
At this point, I think we'll probably move on to questions, and then any further questions can be asked in the question period. Okay, so I think just to reiterate, I don't think there's any sides in this. It's all about safe, effective, affordable hospital care for all our residents. Sir, if you didn't want to be recorded during the questions, you carry on. Okay, so that's fine. So just this is the rules of engagement on questions. We've got just under an hour. Please raise your hand if you want to ask a question, because we want to give everyone, as many people as possible, a chance. And as I've done before, to try and keep balance from all areas, because this does affect the whole of West Hertfordshire, I will ask for questions by locality as we go through. Please wait until the roving microphone gets to you, and if you could introduce yourself and where you're from before you ask the question. If we could stick to questions about this development and not the sort of wider NHS, I think that would be helpful, because there's plenty to ask about this particular issue. And if either there's no time for your question or you'd rather not stand up and ask it, there is an email which I'm sure will be on display later, inquiries.hvccg@nhs.net, but I'm sure we'll put that up later. And we do need to finish very promptly at 9 p.m. Thank you for being so sort of attentive during the presentations, because it allowed it to run smoothly. So if we can have hands, we'll go alphabetically: Dacorum, Hartsmere, St Albans and Harpenden, Three Rivers and Watford. So any questions from Dacorum? Oh, I've got a choice here. Okay, I'll take the gentleman with the glasses on the end.
The microphone's over there.
Oh, sorry, there's one there.
Can I just ask? Sorry. Can I just ask why it's taken all this time of when you shut down Tudor Wing at Hemel, where you've had capacity of bed space, you've moved maternity from Hemel to Watford, and now you're saying what you're saying. So that's been nearly 30 years, because I had my boy in Watford because I didn't know at the time whether they were going to keep Hemel maternity over or not. So I had to go to Watford. At the time when I had him, it was on a Watford match. I work in cardiology now from Watford, and I've moved to Hemel. And when you see the difference in the hospitals and what goes on, I'm not going to say anything else on that score, but, you know, why you had capacity of beds in Hemel that has now been practically wrecked by the local gypsies and taken everything stripped out of it. When you need the bed space, it doesn't make sense why that was done.
Okay, so there are the two different questions really in there. So the first question is, why is it taking so long? And that is it is taking a long time. We're all frustrated with that. I think it comes to some of Don's points, which is we have to be awarded the money. We have to source the finance to do this. It's not something the trust can do on its own. We're not allowed to borrow money because we're not a foundation trust. So we have to go through a process. apply to regulators, get approval from the Department of Health, get approval from the Treasury. And to date, we have not been successful, and there's been a range of reasons for that over the years why that hasn't happened. We did submit a business case 2 years ago. We asked for more money 2 years ago. We had slightly more ambitious plans in terms of the amount of new build. We were told that it was not affordable. The funding was not available at a national level to do that. We were asked to look again and come back with something in the £350 million mark. It is, we still have to go through the process to make the case to the Treasury, through the Department of Health to the Treasury to get the funding. So we have to do that, and that is what we are really focused on trying to do now. And we are.
Why aren't you dealing with the MPs? They're the people who do it for you, and they don't agree with each other, do they?
Well, so it's a key point in terms of one of the challenges for this health system, and I think it is a challenge, is getting a shared view about what we want to do and getting agreement on something that we can move forward with. The other point around the historic issues around the configuration of services and the decision to close Hemel, I'm not going to try and respond to that. Today is about how we move forward from here and how we get to a good solution. And there was a full process and a full consultation and a decision taken at that time, and a strong case for centralising your emergency care services. But I don't think that's helpful to talk about that this evening. I think we need to talk about the future.
Okay, so if we could have a question from Hertsmere. Anyone from Hertsmere want to ask a question? Gentleman there.
Tom Drabble from Hertsmere. Just one question. I was surprised not to see an option, 5 or 6, and that option would be all facilities, both urgent and elective, to be located to one site, to a new site. And allied to that is, with most similar projects, there are a large part of the costs, the displacement costs, where temporarily you're redoing a building and you relocate to a new building on a temporary basis and then go back to the building. And in my experience of commercial projects, that's a very high expense. And I wasn't quite sure I saw any line in the business case for it. But my main question is, I didn't think I saw, maybe I misunderstood it, an option being having all the new facilities located on a new site.
This is the short list of options, and the short list of options had to be affordable within the £350 million capital funding envelope that we talked about earlier. We did look at options in the long list and in the last SOC. So options 5, 6 and 7 were emergency care options on a new site, and an option that brought everything new onto a site. But those options, the costings for those options are significantly higher than 350 million. So in the region of 600 to 700 million. So that is why this shortlist doesn't include options that cost at that level.
Okay, thank you. Any questions for St Albans and Harpenden? No, there was one at the beginning from Decorum. We'll go round. No, we'll rotate, so there will be another chance. Yeah. So St Albans and Harpenden. Anyone from St Albans and Harpenden? Gentleman at the back there.
Stan Alderton. In the Watford option, in the Watford option, you were doing work on a new build and on existing. Is that all taking place at the same time?
Tim.
We've actually worked through a phasing plan. In fact, one of the pictures on the back wall directly behind there shows how we propose to do it. But it's a phased development that starts off based on area that's completely vacant with the first new build. That enables us to move around without ever stopping current operational services with minimum disruption to those. So it is a phased development, but actually a lot of the building can happen at the same time without any disruption to current facilities, because they're in areas that currently do not have either buildings on or buildings that we're intending to keep in the long term.
Okay, thank you. Anyone from Three Rivers?
Do you want to use the mic? This is a question I have asked before, and I notice it's being done more fairly in regions today. But there is a thing called the panel of lay people who are not paid, but they have an opinion and they're allowed to express it. And I've been very concerned that Three Rivers and Watford have been lumped together to have 2. Dacorum has 2, St Albans has 2, Hertsmere has 1. I've also this afternoon gone through the populations. The total population of Watford, Three Rivers and Hertsmere well exceeds the population of Dacorum and St Albans, and yet they only have 3 representatives as opposed to the smaller area having 4 representatives. I don't think that's fair. I've written about it and I'm still waiting for a reply, but I don't think that's very fair. I think we're not being considered equally. Thank you.
So is that a question or is that a comment, really? Just
Well, it's a sort of comment.
comment. Okay, shall we move on? Is that all right? Yeah. Okay, thank you. Okay, Watford. Gentleman here.
Thank you. Steve Palmer, resident of Watford, but I'm also chair of Health Watch. I've got a couple of questions. The first one is a medical one almost. Not that I know much about medical things, but the separation of emergency care and the the elective stuff is not a risk if you actually do separate the two, that something happens in the elective and planned care, that getting to emergency could actually cause a problem. The second question is about the money stuff, I suppose. I mean, you're very clear that 350 is basically what you've been told from the Department of Health and presumably central government. That's actually the cash limit, and that's basically, if you had more, you'd do something. You may look at other options. You've been quite clear about that. Clearly, there is some debate and discussion about that, so I suppose that's just a comment on that. But you have been very, very clear about that, and if anybody else thinks that's not the case, I think there needs to be some sort of evidence for that. The third one is a bit of a problem, a very quick problem, very quickly, is what happens if you don't get the money? How do you actually manage that?
Can I answer question 1, which is the risk of separation of cold and hot services? It is a theoretical risk that if something goes wrong in the cold centre, have you got the cover there? But one of the key components of that is to have staff co-located. So if you're a solitary surgeon operating without your team, then it is a risk. But the whole point of our programme is to put the teams based at St Albans so that actually you've got a full service of colleagues and juniors around to look after your patients if something does happen. So it is a risk, but we can mitigate against it. But the key step in mitigating that is to have your staff co-located.
So I think the question, the statement about turnover, we won't pick up here. But yes, we have been given that very strong steer from regulators, and we've got a letter that is in the public domain that we can share. In terms of what is the plan B, well, that's a good question, because we do need to secure investment in our buildings, and we do need to secure this level of investment in the buildings. So we are going to keep working until we get the investment that we need. We do, in the meantime, and we've already talked about the time it's going to get this delivered, we do need to keep the buildings as fit for purpose as we can, as safe and effective as we can, and we have a certain amount of capital every year that we can spend to do that, and we are making applications for some small amounts of additional capital as we go through. But the quick answer is there isn't a plan B, in the sense that our hospitals need this investment, so we need to make that case.
Okay, thank you. Another question from Dacorum. Gentleman here, I think, was pretty quick with his hand. Thank you.
My name is Mike Prindeville and I live in Hemel Hempstead, but I've been to every one of these meetings over the years, and I'm not really kind of keen on the bit, it's divisory where, we come from Hemel, Three Rivers, wherever. I'm a resident of West Hertfordshire, and what I really want is a hospital that's fit for purpose. And all the meetings I've been to over the years, and I've got no beef with any of the officers up at the front there, because at the end of the day, you have to implement policies, perhaps that you don't agree with, but you have to implement them. So I've got no problem with you at all. But one of your clinicians was saying, I think he was one of the clinicians, was saying that it's a hospital site that's got to last over 60 years, if I've got that right. All of the meetings I've been to, I think there's always been agreement that the Watford site is not fit for purpose. You know, the access, wherever you live in this room, in Hartsmere, wherever, it's where the Watford site is. It's just not fit for purpose. I think we've always acknowledged that the care we've had, I was in Watford in the stroke unit for 4 days, 2 years ago, and the care was brilliant. But when my family had to come to visit, they spent over 80 odd quid parking to get to Watford. So it's two things. I don't think the site is fit for purpose, and so you could be throwing money on a site that, you know, is very inadequate. And the other question is, with the car park, and I've always been interested in the car parking, St Albans, last time I was at this meeting, one of the officers said that they would have to put a park and ride in St Albans because there's an inadequate parking in St Albans. But would that car park, the proposed one in Watford, be a free car park, and how many people would it hold?
Okay, so really about the parking and the site, I think.
So, very quickly to pick up on your 3 points. The first thing, in terms of the site itself, it's about the size of the site. Is it big enough to do what we want to do? And we're very, very satisfied in the work we've done so far that the Watford site is big enough for us to build the new emergency care hospital that we want to do on it. The second issue about the Watford was access, and I think we do need to acknowledge the difference that's happened in the last couple of years to access to Watford. We've got a brand new access road that's come into Watford now that takes you from the just let me finish, please, with what we're saying. An access road that brings you in and significantly shortens the journey time. I travel between the hospitals on a very regular basis, so I know the impact it has, and we know the feedback we're getting from it. So it has improved access from locations, some more than others we will accept. In terms of the car park at Watford is going to be about 1,450 spaces, of which 1,295 of those are allocated to the trust. That means overall we get about 100 more car parking spaces than we've currently got at the Watford site, which will cover the peak demands that we've got at Watford. So in terms of capacity going forward, we will have the capacity, and I think it's important to note as well that we're going to double the number of disabled spaces that there are at the Watford site, which again will have a major impact on the ability of people to park when they get there. Finally, picking up the St Albans issue, the big challenge with the St Albans site is its location and the ability to expand. There is no way that we can increase the number of car parking spaces on the St Albans site at the moment. So if we're going to bring more services into there, we will have to improve the car parking. And one of the options we're looking at, not the only option, but one of them is a park and ride somewhere outside to bring people in. And that'll be predominantly staff that come in, because obviously the patients at shorter duration are going to have to come in and park as near as they can to the hospital. So it's an option we're looking at, not necessarily the final solution to it.
Okay, thank you. Any questions from Hartsmere? Lady at the back there.
Hello, my name's Shirley Berry. I recognise that you're having to take some very uncomfortable decisions, some of you with perhaps you don't believe in your heart, but your role in the Trust asks you to do it. I'm just looking through. I mean, we have a lot of elderly people where I live in Shenley, and actually I can't drive them for health reasons. And I have to go around the different hospitals. I have to go to Hemel sometimes. It's absolutely impossible. Sometimes you can get community transport to help you out. Otherwise, it costs me over £40 to get to Hemel Hempstead. You're not thinking about people who have to go by public transport at all. You're centralising services. We can't access them. There's no bus service straight to Watford either, actually, from where we live.
Yep, I think Helen might pick up the travel, but in relation to the service, I just want to bring back to what we said at the beginning, that part of the work that we're doing across the NHS isn't just about hospital buildings, it's about the majority of services that actually sit outside the hospital and sit in the community. And the strategies that I referred to at the beginning was about bringing care closer to home. and ensuring that as least possible time of having to journey when you're in to go to hospital, you had to take that place. And therefore, we've been investing in quite a lot of community services and primary care investment in order to improve that. So that's at the heart of our strategy. And we'll continue to do that, and we'll continue to do that well before the years before we're talking about in 2023 to improve that position. And actually the strategic outline case is predicated on 40% of outpatients sitting in the community, being out of the hospital sites, and therefore we're really comfortable that we'll be able to improve the journeys that you're talking about for the majority of the patients of West of Hertfordshire.
So if I need to have a planned operation or something at Hemel,
so that is different. So I'm talking about community and primary care. And actually, we've got to remember that 80% of the activity that sits in the NHS actually sits in primary care. So yes, there will clearly be opportunities where people will need to travel for different operations and planned care that you're talking about, in the same way as people go for specialist care perhaps into London at the moment. But at all times we're keeping at the heart of what we're doing, the decisions that we're doing in those cases, the best clinical expertise that we can provide to patients at the time when they need it. But what we are clear is that the future, the sustainability of the NHS is about ensuring that we've got really strong primary and community care in all the different communities in the West of Herts. And that's what a lot of this is all about in making that work.
Yeah. I don't need the mic because So I think it's a fair comment, and it is something that we discussed in the stakeholder group, is that there are challenges for people to get to hospital services when they need to. So yes, we hope to reduce the amount of time people come to hospital, either because of the things Catherine's described, or actually, as Freddie described earlier, by just organising the services better. So we're not asking you to come multiple times when we could do more things on one day. So that is really important. But we acknowledge, public transport in Hertfordshire is not perfect, and particularly going east-west. So we will be looking at what we can do, but it is not an easy it's not an easy challenge to solve.
Okay, I think we'll allow some time for other questions. Anyone from St Albans got a question? Lady at the back there.
You say the cost you've got is 350 million. How much are you going to get for the housing you're going to be building on all these three sites? Is that going to be over and above the 350 million? In which case it could all go towards a new hospital.
Just the guidance we've got on building up the capital prices say that we have to build them up to begin with without taking account of land values. I think if you remember one of the slides that we showed earlier on, it did show the impression of what happens to land value. We have worked out the land value of the housing that we can build on the sites, and we've looked at those for all of the 4 different options. But the difference, because you have to buy the site, if you go to option 4, you have to buy the greenfield site. So yes, you get a saving on the 2 sites you sell, but you buy the new site. So what we showed was the net saving on each of them, and what you find is the net saving on each of them for land values is somewhere around about 10 to 25 million, which against the 350 million overall is actually is less than 10% of the total value. So even if we were allowed to keep that, which is a question, if we are allowed to keep it, it still has a minimal impact. It certainly doesn't allow you to get anywhere close to 400, 500 or 600 million to build your new hospital.
Okay, thanks. And any more questions from Three Rivers? Gentleman there. Hold on, wait for the mic, please. If you introduce yourself and...
Yeah, sorry. Edward Hawkins. I live in Abbots Langley. I've lived in the area all my life, actually, all this area. The question I've got is in bed numbers. I haven't heard anything mentioned about absolute bed numbers. Now, we're currently obviously aware that we have one of the lowest bed ratios in the country. It's less than 1 per 1,000. And I wondered what impact that's going to have, because we've got an enormously growing population, far more than anyone's prepared to admit to. And I want to know what we're going to do to increase the number of beds, because it's not going to be a simple matter of keeping things the same. And I haven't quite got from this. No one has mentioned bed number at all.
Bed numbers are quite complex, so I'm not necessarily subscribing to the 1 per 1,000.
Add it up and try it, because I've done it and I've seen it in writing on the internet, so I know the figure I got was wrong.
So I've looked at different numbers on the internet as well. It's what counts as a bed. But so just to bring it back to what I do know, which is how many beds we operate from now, and
per amount of population, because it has to be related to that. The bed number's irrelevant unless you're talking about an increase in what you've got now.
So, and again, it's in terms of what the population is we serve, that is determined by the catchment area. So we don't serve the whole of Herts Valleys. People do access care at Luton and Dunstable. They access care at Barnet Hospital.
They access care
It
works both ways.
No, it doesn't quite. It doesn't work both ways.
What they told me even today.
So there is. There's more than one hospital that serves the residents of West Hertfordshire. So yes, I work for West Hertfordshire Hospitals Trust. We provide a significant proportion of the hospital care for local residents, but we do not provide all of it. A lot of people from Hertsmere travel to Barnet. A lot of people from Harpenden travel to Luton and Dunstable. So you can't take the Herts Valley population and compare it to our bed base. However, and I don't want to get into an argument about beds per 1,000 population, what I can tell you is that if you count all of our beds currently in the acute hospital trust, not the community beds, we have about 900 beds. Now that includes beds that you will think of, acute medical and surgical beds, so that's what most people have in their heads when they talk about beds, but it also includes day surgery beds, day assessment beds, neonatal beds, maternity, antenatal, postnatal beds. So it's everything that is not an outpatient or a accident and emergency type attendance. There's about 900. What we've done when we talk about how we're going to build the hospital for the future, what's the right size for the hospital in the future, that is actually really quite a difficult question to answer, and we will continue to do this as we work through the process. So we keep updating the figures, but we take what we've currently got in terms of activity. We look at what population growth we expect to see, so we use ONS figures for that. We look at what we call non-demographic growth, so demand for hospital services grows faster than the population grows, and it has done historically because well, I'm going to get to a number for you, but I'm explaining some of the complexities of the modelling. Having said all of that, so if we took a straight line and modelled it forward, you would certainly expect to have more beds. However, we are working to change models of care and reduce the number of people who get admitted to hospital, and make sure that when they are admitted for hospital, they only stay for a shorter time as clinically appropriate. And we know that sometimes people stay longer. So we have to take all of those things into account as we plan for the future. Effectively, based on the transformation plans that we have, we're working on the same number of beds in the future that we currently have. That's the current assumption.
That's what I wanted to know.
Yeah.
I can talk to my MP.
So that's the current modelling. As I've said, we update it. We will update it. Outline business case, full business case.
Okay, thank you. Watford, gentleman here.
It's not Jim.
Thank you very much. My name's Ian Stotesbury, and by a statement, I'm a councillor in Watford. So thank you very much for the presentation. I think it was really interesting. There are a couple of numbers on there that I think would really help the audience, and frankly myself, I've received the briefing, but it would be very useful. You spoke about vulnerable people on one of those slides, and I think it's really worth, explaining the justification for why option 1 is the preferred option from your perspective for vulnerable people and people in vulnerable circumstances. And also clinicians, the people who actually serve us, who actually work for us, the NHS, in that stakeholder table. I think also option 1 was the priority or the preferred from then. And I thought maybe you could justify that for us as well, because they're 2 really important pillars that I think go beyond geography for me. Thanks.
I'll answer from a clinician point of view. We work in, anybody who's walked around Watford Hospital, you can see the decor. It's awful. Our juniors, most of us don't have offices. If we do, they're hot, sweaty, no windows. And so refurbishment of that has a huge uplift for the staff. And the majority of staff work at Watford, so there is a very significant advantage from a doctoring, nursing, clinical staff and clerical staff to actually get that estate sorted out. It will lift morale enormously to work in a building that is fit for purpose.
Can we just pick up as well from a patient perspective? So I've got 2 mics, which is too much. 2 mics is 1 too many. I mean, lots of patients. We have lots of patients on all of the hospital sites, and many of them have additional needs, sensory or physical disabilities. The reason that we think we should focus the investment into the emergency care site, happens to be at Watford, but it's into emergency care, is it's the highest volume site. We're an acute hospital, and most of what we do is emergency care, about 75 to 80%. That is and the patients come to us at Watford for emergency care when they're at their sickest and most vulnerable, and they inpatient care, you sometimes need to be in the hospital for quite significant periods. So when we look at where we should prioritise making improvements to the estate, we do think there is a strong case for prioritising investment into emergency care services. So that's one of the key drivers for why we've recommended option 1.
Okay, so back to decorum. I don't know, you choose.
Oh. Hi, I'm Jenny Thomas. I was living in Watford and I've recently moved up to Bovingdon in Dacorum. And although there are times of the day when it is easy to travel down from Dacorum into Watford, there are many times of the day when it's not. Oh, and I would be very interested in, has the Trust actually consulted the ambulance service about what they think about the various proposals? And also, if you're considering looking at option 2, have you objected to the proposed moto service station? Because that's hugely going to cause a problem in moving around.
What was the first part of it?
I'll take the ambulance. So we have had the ambulance service inputting to this process. They were on the stakeholder panel. We do work closely with the ambulance service. I mean, the reality is that at the moment, emergency care services are at Watford and the ambulances have to access. And with a blue light ambulance, you do get through the traffic and the traffic gets out of the way for you. The ambulances take patients to the nearest hospital by travel time, and clearly if we were to move emergency services, we would have to work really closely with the ambulance service, and we did when we were looking at options that looked at new sites for emergency care 2 years ago. We did work with them, but I live and work in Hertfordshire. As you say, sometimes it's fine, sometimes it is challenging, and that is a reality of Hertfordshire. I can't remember what the second bit of the question was. The moto services. So that's Tim. Do you want to pick that?
Yeah. We have done extensive travel modelling that looks at journey times for all different groups coming in and out of all the different hospitals. So we have got that background information, and some of that has been released as part of the packages that dealt with the long list to short list. As the particular issue to do with the service station, I have spoken to the planners at Dacorum Council, and I know that there is, and it's actually an HCC responsibility rather than Dacorum themselves, plans underway to do major development of that motorway junction. So any service station that did go there would be linked to a development of that junction of the A41 M25, which is already on HCC's plans. It isn't anything to do with the hospital, that's to do with the wider access there. So there will be allowances for that, but not the motorway. We haven't made particular allowance for the service station in our considerations. Yeah, as I say, the location of the service station wouldn't determine the hospital. It's the access routes in and out, and the development of that junction, which belongs to HCC. We have spoken to them. We are aware of their development plans.
They're not talking about improving the junction under the M25. They're talking about adding in an addition.
Yeah, I'm not sure we can add much to that at the moment. Okay. So, sorry. I think we'll move on to a different aspect. So, Hertsmere, gentleman at the back there. You from Hertsmere?
I'm perhaps the oldest working member of the health service profession. When I started doing the Blitz, my training at Moorfields Eye Hospital, and since then I have seen a great many improvements and changes to the health service. What concerns me actually is the disposal of land in Plan 1, because by keeping the land, you would enable further developments. Would there be, if there are required in future, is it possible to retain the land in Plan 1 to Watford General Hospital?
Certainly, you're quite right. We absolutely need to have flexibility in any of our future plans. So the first thing to point out is the land that we would offer up under option 1 as shown there is less than the land take that we take for the new multi-storey car park, which is actually not on hospital land, it's on council land. So the net difference between our current estate and the future one remains neutral as far as that. But we wouldn't hand over any land till we're absolutely certain we'd kept enough for our future use. And if you go back to the plan that you had there that we looked at for option 1, you'll see we're retaining enough space to build another building the same size as our main hospital building with up to 24 to 30,000 square metres without even using that land that we're highlighting for disposal. So we have a lot of spare land available at the Watford site to develop, but we wouldn't dispose of anything else until we're absolutely certain we didn't need it over the next 20 to 30 years.
Okay, anyone from St Albans still have a question? We'll be round to them again in a sec.
Stan Alderton again. The cost you've got here for departmental costs, I believe it was based on a department area. Rephrase it. How did you get the department costs on these exercises?
Yeah. Oh yeah, I have, haven't I? Yeah. I made reference to. Let's just switch this on. I made reference to health building notes. Is that what you're referring to? So there are nationally published figures that tell us how much we should allow per square metre for different elements of a hospital. So with an outline design for the hospital, taking into account expected bed numbers, expected demand for care, we simply multiply those areas by the notes for cost per square metre to arrive at those departmental costs. Was that the question?
Stories that you can get a new hospital for a lot less than what you're thinking on these numbers. Yes.
All right. No, that's simply not true. If we are mandated. The important question, I mean, you will look at examples of where organisations have built new hospitals for less. The cost of building, the building inflation moves pretty quickly. I mean, if you know the trade, you'll see that. We're mandated to take into account nationally published figures for building costs per square metre. And also, as I described in the slide that I put up earlier, we have to take into account costs of fees, other sorts of on-costs, and also that factor that we talked about before, optimism bias. The Department of Health looking back at business cases that have been submitted to them in the past, have noticed that the ultimate cost that the organisation ends up paying is often much more than the amount that's put in the business case. So we need to take that into account as well. Our business case would simply be rejected if we didn't take these factors into account.
On a previous example.
I think we'll move on to the next question because there are lots of people still wanting to ask. Three Rivers, anyone? Okay, this gentleman here.
John Grillo, Croxley Green. Page 41, summary of scores according to stakeholder group. With reference to option 1, clinical and trust other stakeholders groups score highly in favour of option 1, but CCG other and other score quite highly in favour of option 4. And I'd really like an explanation for that discrepancy. And I'd also like to know what other is, because other is just a 5-letter word.
As I said when I talked about the stakeholder panel, we had just over 30 people in the room. And they came from different organisations, but we didn't want to list. So other includes, we had representatives from the Community Trust, the Mental Health Trust, from Health Watch, although I think we put Health Watch under patient representation. So other is from organisations other than the CCG and the Trust. In terms of the CCG scores, and we have discussed this with the CCG, so the representative in the room, the representatives in the room on the day from the clinical commissioning group everyone scored individually, and that was the individual scores that came through on the day. There has been quite a lot of subsequent discussion with members of the CCG board, with GP colleagues, and I don't think if we asked all of them to score it that would look like that. But there are benefits to the new Plan to Care hospital, and people were attracted to the opportunity to bring those services together to have a whole new build in an accessible location, and the scores reflect that.
Okay, Watford. This lady here was last time waiting.
I'll come back next. Thank you. My name is Fikile. I've got just very few reasonable questions, I assume. The accuracy of your findings is questionable. You cannot have only 30 people representing the public view because there are so many people who have not been consulted, and now you're taking a decision on behalf of them, and I suppose that is done by the leadership. That is unfair. Secondly, the deficit of the trust is very high. I don't know if there's any reserves or any other approach to get it down. If there's such, then how can you do that? Then thirdly, how do you make sure that your decision making is in the center? In the center of your decision making, you're having us, the patients, us as the public, rather than the leadership deciding upon the needs of those who are going to suffer. Thank you.
Okay, so I think the first one was more of a comment. Second one I'll hand over to Don for the finance bit. Is that all right?
Absolutely right. The deficit is very high. Last year we spent £50 million more than we brought in by way of income. We do have a plan this year to get that deficit right down to 23 million. Just about every acute trust in the country is running a deficit. The way the system works at the moment, there's a price for acute care, a national tariff price. That tariff is insufficient to pay for the unit costs of healthcare, especially when a lot of your care is emergency care. That's a particular problem. However, you may remember that I talked about our cost improvement programme. We know that we can do things more efficiently. We know, for example, that our outpatients department is inefficient. We can modernise that, and we can see more patients as a result of the changes that we intend to make. I think we have 7 wards that have 18 beds or less. One of the advantages that we're going to get through this redevelopment is getting our wards to the optimum size so that we can make best use of our nurses. So we don't need as many nurses to look after the equivalent number of patients. You can imagine the diseconomies of scale we get from very small wards. You remember the slide that I put up earlier? That showed that we do expect, with the ideas that we've got at the moment, we do expect the deficit to reduce. But if we don't get the investment that we're asking for at the moment, the deficit will get worse again. So that's why we need to make this investment and get to break even.
Okay, and your question about engagement. So I think I talked to earlier about the extensive engagement that we have undertaken. All of the views that have been heard either this evening throughout the many months that we talked about earlier have all been shared and discussed with our boards on many occasions. In fact, at last week's meeting, we had representations presented to the board, either sent to us in advance, and an individual also stood up. So I can assure you that all opportunities, including from the advisory panel, and everybody who's opportunity to contribute has been in consideration in where we've got to so far, and we'll continue to do so as we go through these steps. It's the heart of everything that we do. That's how we operate. And if you take the CCG board, for instance, we actually have lay members. The trust have non-execs on their board, but we have lay members. We have patient representatives that sit on the board, and they're all part of this process and the thinking. So we do actually take pride in the fact that we have engaged with a lot of people as part of this process, and we'll continue to do so. And that's what we're here to do this evening in order to listen to your views.
Okay, so I think we're back to decorum. I think Mike's caught my eye and wants to do that on behalf of decorum, if everyone else is happy from decorum.
So I've been unusually quiet. So my name's Mike Penning. I'm the MP for Hemel Hempstead. And while I represent Hemel Hempstead, I hope I try and represent everybody's views, in that what we want is a first-class health service in this part of the world. And to get that, we need to be able to trust what we're being presented by people up on the top table. And some of this is really worrying to me, because I keep getting told we can only have 350 million because that's what our turnover is and that's what it's based on. The directors up there know that we can test that. And Harlow, for instance, is already going ahead with a project which is completely separately funded. No one understands why there's different health trusts. You know, there's a community health trust. Catherine just alluded to the mental health trust. Those budgets are being taken in other projects into the scheme. So why don't we keep going on about 350 million is the only way the government block anything else? That is technically not true, and we know that. When I met with the Minister with the hospital action groups the other day, the information that the Trust gave to the Minister was inaccurate, and that's a polite way of putting it, and he's had to write back and ask why it was inaccurate. So we have to trust you in what's going on, and by ruling out any chance of a new hospital with acute services being built, and no one wants to take anything away from anybody. What we need is a 21st century hospital provision. And none of that, on those options up there that I can see, and I know some people in the room would disagree because I think they're losing something from here or losing something from there, has to divide and rule. That's why the MPs can't agree. But what we do agree on is that we need something a damn sight better than what we got now. And what we need is the truth, the absolute truth as to what's going on. The stakeholders asked the option to be kept on the table. Edie Gladder did that to make sure that there would be an acute hospital part of that discussion. It wasn't there. We keep talking about this is the option now and we want the best care. Frankly, how can we believe you? We had invested in your health, and the lady earlier on said we have to move forward, and I accept that from the sedentary position. She said, but we're in this position with that hospital in Watford because of what you did invest in your health and closing Hemel. That's where we are. And so you can't, the blame game has to stop with the management, not with the patients and the residents.
Mike, I think I might differ from you on that one. We agreed on a new site, and actually the politicians then wanted to keep it at Watford. Sorry, Mike, I remember that. Right, Mike, was there a specific question there? Because I think that was mainly comment. Okay. Well, that's not a question, so we'll take your comment, and we'll take a different question from decorum.
Okay. Good evening. My name's Jan Madden. I'm an independent borough councillor in Decorum. I also am a member of the New Hospital Campaign Group. Over the last few years, the clinical director of the West Herts Hospital Trust has been saying that it is imperative we have a hot and a cold site to separate clinical and planned surgery. Last week I went to the board meeting at Watford Football Club, where he said that the same person said that option 1 is the most suitable because most planned surgery is done there. This completely contradicts what he's been telling us for years. Option 4 offers an increase of patient care in a central location and goes some way to the solution that the Trust insists is what is needed. If his statement last week is his honest opinion, it blows the hot and cold option out of the water, which puts me straight back to what's the point in having 2 sites? How can you possibly discard option 4 if your clinical director believes that the requirement is to have 2 sites, one for hot and one for cold? That would make a much bigger site for the cold surgery. How can you have confidence in an influential member of the board if he can't decide himself, because 1 minute he's saying one thing and 1 minute he's saying another? And one more thing. If, again, at the beginning of this meeting, and we had a meeting with Helen and with David last night at Health and Decorum, which I sit on. They're still telling you tonight that they haven't made a decision. At that board meeting last week, where every member of the CCG board was there and the West Herts Hospital Trust board was there, they went round and they asked every single one of them at the end of it which was their preferred option. And all but one said option 1. So don't believe that they haven't made a decision. They have.
So yes, David and I spent a couple of hours at Health and Decorum last night and went through this presentation then. And Councillor Madden did ask me that question last night. Mike's not here this evening. I can see Mike's not here this evening to answer, so I will give the same answer that I gave last night. At the board meeting last week, Mike was expressing his view for the rationale for investing in significantly in the Watford site. He did say that most of the planned care activity takes place on the Watford site. In fact, I've got the numbers. We shared them earlier. At the moment, it is just over half of the planned surgery happens on the Watford site. And in the future, we do expect to put more of the planned surgery into the cold site. Now, whether that's St Albans or a new site, the plan is to push as much as we safely can of the planned surgery to a separate site. Mike was making a broader point about the volume of activity at Watford, and as we've already described, the significant majority of the work that we do in the hospitals is emergency care. So planned surgery represents less than 10% of our work. So it isn't the material factor in that decision. Mike absolutely stands by a separation of hot and cold where that's clinically appropriate, and putting as much of the planned surgery at St Albans under this option as we safely can. So on that point, that's what I said last night, and I say the same tonight. The issue on decision making, and again I did respond to this last night as well, the formal decision happens at the board meeting, the trust board meeting on the 11th of July and at the CCG. The board meeting we had last week was not a decision-making meeting. We did have the discussion and do that in public so people could see where we expect to be recommending. We've got to write the business case that has to be finalised and presented. So we were aiming to be transparent and share with people where we were at. We had a good discussion, but the majority view absolutely was in favour of option 1. And as I said last night, I'm not saying that we haven't discussed this in other places. Clearly, this is a really important decision, and the boards have debated it, and that is reflected in the views that were presented.
Okay, so, and just from my point of view, on that meeting last week, I will happily say I said option one on the evidence that I'd heard that day, and the swinging argument for me was about the improvements in the very acute end of care where there are so many problems at the moment. So the ITU, the A&E, the maternity, and if we'd gone for option 4, there would have been a lot of money going into planned care, but we wouldn't get the really important improvements for health for the seriously ill people that we get in option 1. So that I'll explain my rationale, and that's what it is. Okay, sorry. Okay, on to anyone from Hertsmere got another question?
If we don't let them
say
something, they're going
Sorry, can I just speak? I'm a nurse in A&E at Watford. Oh, okay. Right. Hello. I just wanted to say I'm a staff nurse in A&E at Watford. So obviously I'm just like looking at it that the new planned care obviously doesn't have an emergency. Sorry?
Keep waving it away.
Oh, sorry. All right. Okay. Oh gosh. Yeah. Okay. Right. Hello. Right. I'm a new staff nurse and I work at Watford in A&E. And actually, I did work the day all the sewage was down and half of A&E was closed. It is desperate there. I mean, it's just desperate. And obviously, if Watford is the A&E that's going to still carry on supporting the whole of our area, Hemel, Hertsmere, everywhere else, we do need investment in it. The nurses, I don't know how they would get to other places. But yeah, no, I mean, as a nurse myself, I would want option 1. So. And I live in Decorum.
I'm Alan Brompton and I live round the corner. If we need emergency care, we end up in Watford, no question. But if we have any other sort of care that we need, we tend to try and go somewhere else. Now, what I want to know is, in your thinking, how do you take account of the fact that if you then improve the service that you provide here, then I will change my mind where I want to go, if I can, because obviously it's more local, whether it's St Albans or whether it's Hemel. And how does that play into all your number crunching for beds and so on?
I know we are running short of time, so
to keep it brief, but one of we call that market share, which is a bit of a commercial term for an NHS service. But we do expect that if we improve facilities, we will expect to see our catchment area increase and the percentage of patients come through, and that is factored into our future demand projections. Now, we haven't got a crystal ball, but we're doing our very best to be as accurate as we can in estimating the future level of need.
Okay, gentleman at the back's been trying for a long time, and we are at the end, so I'll let him have a question.
Thank you very much. My name is Hamid Mistry. I live in Watford, and I also represent a large number of communities throughout Hertfordshire. What concerns me is this. I mean, I'm not against the development, because obviously that's clearly needed. But for me, I think you've gone backwards rather than forward, in a sense that we have heard nothing at all about the people's demand, what the population is going to be, what the elderly requirement is in terms of transport, etc. That demographic has not been put up, which gives you the argument for the development, whether it's going to be in Watford, St Albans, or Hemel. And that evidence is needed in order to actually make a proper judgment. Not only that, there's a young lady who actually asked a question there about consultation, about involving the community. You haven't answered that question. You've got your stakeholders, but people like me are a stakeholder. Yeah? Are we not involved? And if you talk about, Health Watch, etc., there are gaps in terms of which community they can actually speak for at the moment in time. I can tell you there are lots and lots of community organizations who are not being consulted at all. And I think that's a mistake that you have made. You have put the cart before the horse. You have not taken into consideration the needs of the public. You have not actually asked the public in terms of what the issues and needs are. And if you're only going to have the same amount of beds, what's the point? What's the point?
Okay, so 2 quick points there before I know we're short of time, but yes, we're quite happy to include the growth rates and the stats in the presentations to do on the 11th. That's a good idea. We've talked about that at length this evening already, but we'll include that. And the second point, I think I did talk about extensive engagement, and the fact that you're here talking to us this evening is all part of that process, and we'll continue to do so.
Okay, so they have been.
So we do.
They have been.
Yep, they do that. There was a PPI committee today, specifically I referred to earlier. That was one of many that have taken place. Many different PPGs have been discussing this topic, and all of that feedback is included as part of the engagement and responses.
Sorry, if we are part of the process and we say to you tonight, we don't like any of these options, we want option X, which is go back to the government, a brand new hospital. The centre of gravity of your estate is north of the M25. Do we actually count?
We can I think we'd take it into account when we make our decision.
Get a show of hands today.
So of course we do, but we're probably getting into the summary position actually, which we need to get into. But there is, and I know, there's a couple of gentlemen over here. So before we move it, and I will pick up your point when I do that. Yeah.
We've been trying for a long time, I think.
All right, thanks, Catherine. I'm County Councillor Nigel Bell. I'm the County Councillor for West Watford, which obviously takes in and it includes the Watford Hospital. I just wanted to say, I don't know if Mike Penning's still here, but we've all had to compromise, Mr. Penning. We would have liked, probably most of us in Watford and even nearer to Watford, a new 600-bed hospital, which we thought we were going to get years ago. Now that's not happened. I'm not going to get into politics. I'm not going to get into the wider politics, but we are where we are, right? We've got that 350 million. I'd just like to say to Catherine, with the fact that I'm pleased that option 1 is now going to be the preferred way forward, what honestly could stop that being now given the green light on the 11th of July? From what I've seen and heard from the other meetings we've had, it looks as if option 1 should go ahead on the 11th of July. Can you give me any solid reason why it shouldn't?
Okay, thank you, Nigel. So I'm not going to give you that assurance because, as I've said, and I think Helen referred to, the decisions are not made. We're still completing this process. We're here this evening, want to gather all the feedback. People will continue to provide that feedback, and that will all be included when we have separate decision-making meetings on the 11th of July. But what I've given you this evening, and we started at the beginning, was to inform you of where our thinking was at this stage. I'll continue to stand behind that. I know Christine will do that in a moment. And on the balance, picking up the gentleman's point that was raised to us earlier, on the balance of all the feedback that we've had, all the views that we've taken from people, and living and breathing this over a number of years, all the financial, the clinical, the staff, and every single bit of feedback that we've had, on the balance of all of those positions, and the clear direction that we have had from the regulators, is that we only have £350 million to spend. There's a divergence of views across the political landscape, but they've also been clear with us that there's a big opportunity here and we mustn't lose it. So therefore, taking into account all the balance of all of those things that we have heard, we believe at this stage the emerging preferred way forward would be option 1. And I know Christine would want to add to that now.
Thank you. Okay, I just want to finish up, firstly by thanking all of you for coming tonight. What I have to say is I can absolutely feel the passion in the room. It is important to all of you that we get on and we improve services for patients. So thank you all for coming here tonight. I'd also like to acknowledge the Hearts Valley Hospital Group. We are going to meet with them. I'm not sure that they've had any chance to speak tonight, but we are going to meet with them and take their views on board. Hopefully, what we've tried to do here is give you a better understanding of the options, a better understanding of our emerging way forward, as has been described. The important thing from my perspective is that we get on, we make a decision, and we improve facilities for patients. Thank you very much.
Thank you, and safe journeys home.